Again, you have to look at all those things which can result into abnormal or which gives you a suspicion of abnormal communication of the CSF space with the inner ear space, which can lead to a gusher. So, like yesterday we saw, we need to look at the dimension of the intra-auditory canal. If it is over dilated, can give you a suspicion. See this cochlear aperture modulus, it is intact. If it is deficient, cochlear aperture widened, can give you a suspicion of a gusher. Then the vestibule, if it is dilated, can lead to a gusher or a oozer. Then vestibular aqueduct. You saw in this section yesterday vestibular aqueduct. See where the vestibular aqueduct is. This is vestibule from where this thin, very thin aqueduct going J-shaped aqueduct and opening as a set at the posterior petrous ridge. This is endolymphatic duct system. If it is dilated, you have to be suspicious about it. It can, if not gusher, can lead to oozer. And here, this is looking absolutely normal. How can you suspect a dilatation of endolymphatic sac? At this diameter, at the largest diameter, if it is more than 2.5 millimeter, you can be suspicious of this. Or in the many times in otosclerosis surgery, a facial overhang can make your life difficult. And the CT scan gives you a complete insight about the core meatus, the facial nerve labyrinthine segment. This is the first JNU. This is the first JNU. This is the GSPM going anteriorly and the facial nerve going behind. That's the facial nerve horizontal course. Look at the entire horizontal course, which looks intact, covered by the bone. It is nowhere looking dilated or dehiscent. See, overhanging facial nerve has to be dehiscent. It cannot overhang with a canal, bony canal intact. It has to be dehiscent to become overhanging. So here, an intact canal rules out the possibility of being dehiscent. Then this facial nerve goes here. This is the second genu covered by the bone all the way. To see the relationship of the facial nerve to the foot plate, we need to look at the upside down picture, that is coronal one. See the coronal picture. That's the vestibule, that's the superior canal, that's the lateral canal, and in the anteromedial lap of the lateral canal is the facial nerve. Can you see the facial nerve? Hello, auditorium?
Yes, sir.
Is the picture going?
Yes, sir. Yes, sir.
This is facial nerve.
Yes, sir.
Now look at the ossicular chain. Malleus, incus, the stapedial crust, and this is the foot plate, and this is the facial nerve. Level of the foot plate, which is below the level of the facial nerve. Had this been an overhanging facial nerve, this facial nerve would have been situated over here, down right over the foot plate. So you can see the relationship with the foot plate and the facial nerve above. It could be a little bit seen projecting on the CT scan, but it is not overhanging at all. See, the foot plate area is wide open with the crust going inside towards the foot plate, and the facial nerve level is above the horizontal, see the upper level of the foot plate. Can you make out very clear?
Yes, sir.
Hello? Can you make out?
Yes, sir.
So see the foot plate and the level of the facial nerve, which is above the level of the upper border of the foot plate. You can see with little bit prominence you can see, but not overhanging. So this is the best view, and we must look at the CT scan in all sections to rule out this facial nerve prolapse or overhang. Otherwise, if you don't have a CT scan and find such kind of prolapse and overhang, either you need to abandon or counsel your patient, or if you are not aware of, not experienced, can even give rise to a facial nerve damage. So we have to be careful in assessing, and this way you can surely prevent, cutting a sorry figure to the patient.